Well, you've all been very good. You haven't asked a single question. I was expecting you to put your hand up and interrupt, but you're obviously...
I've got a question.
You've got a question.
After you've treated my thread veins, will they come back?
Good question. A question I get asked a lot is, I have thread veins. If I have them treated, what are the chances of them coming back? Well, that's a very good question. If there's an underlying problem with the veins, if there's reflux, then that should be treated first. And often, after treating the reflux, the thread veins tend to get better of their own accord without any other additional treatment. However, if there's no reflux, or if the reflux has been treated and they don't get better, they will need injections by microsclerotherapy, as I've mentioned. Now, veins that have been treated are unlikely to come back, but other veins nearby may cause problems again. So, unfortunately, veins are made principally of collagen. And we know that collagen changes with time. When we look in the mirror, we see our skin changes with time. The skin I have now is not the same skin I had 5 years ago. The veins I have now are not the veins I had 5 years ago. The collagen has changed and it has deteriorated. So all vein problems, regrettably, get more common with time. As we get older, more varicose veins, more thread veins, not inevitably, but the risk. Now, if you've had veins treated, veins that are healthy now may become a problem in the future, and they may require additional treatment. And this is a particular issue with thread veins. You're quite right. If you treat thread veins now, it doesn't mean they've gone, you're never going to have vein problems again. It's quite likely that you will need or desire to have more thread vein injections as the years go by. And I usually say to people, have your veins injected once a year or once every 2 years to keep them under control. The analogy is it's a little bit like weeding the garden. You spend a whole weekend getting the garden looking as good as you want it, and you don't then say, well, that's it, never need to do anything in the garden again, because the weeds will regrow. Another analogy which is sometimes helpful is it's a little bit like visiting the dentist. You don't go to the dentist and have a lot of work done on your teeth and you say, right, that's it, never need to see the dentist again. Tooth decay continues, you need to keep your tooth health or your dental health under review. So vein problems tend to recur and tend to progress with time. So a lot of people now come, after successful treatment, come and see us once a year for a scan, for a checkup, to allow us to identify vein problems at an early stage. We can usually rectify with foam sclerotherapy before they become a major issue. And this is certainly a trend that has been in continental Europe for many years. The French do that regularly. You see your doctor, you see your dentist once a year, your doctor once a year, and you see your phlebologist, who's a vein specialist. You see your phlebologist once a year.
Okay, thank you.
Thank you for that good question. Has anybody else got any questions? Because you've been very well behaved. You haven't interrupted at all recently.
I've got a bit
Nikki.
of a question. I don't know if I missed you saying it earlier. You were saying about the complications of varicose veins and one being DVT.
Yes.
So does that mean you have to have varicose veins problems before you get DVT?
No.
Or is that completely separate?
No. That's a good question. Does everyone who develops a DVT have varicose veins, or are there other causes? Well, it's only a minority of people who have bad varicose veins who go on to get a deep vein thrombosis, and equally, for the majority of people who have a deep vein thrombosis, there is nothing wrong with their superficial veins. Varicose veins are a risk factor. They're not a very strong risk factor, but they contribute. In fact, you may be surprised to know that the strongest risk factor for a deep vein thrombosis is going into hospital. Yes. So as soon as you go into hospital, that's a time in your life when you are at greatest risk of developing a deep vein thrombosis, for whatever reason you go in. Obviously not as a visitor, that would be silly, but if you're a patient and you go into hospital, that's a time when you are at great risk of a DVT. Why is that? Well, because you're sick, for a start. The second is you're going to be put in a bed and immobile, and there's something wrong with you. You may have heart disease, diabetes, infection. You may have had major surgery, and the blood flow in your deep veins may not be good. Particularly during a long operation, there may be very little flow in your deep veins. If you're immobile in bed, recovering from trauma or recovering from major surgery, you may not have very much flow in your deep veins. And we also know that when you're ill, your blood becomes more sticky. It becomes more coagulable, more liable to clot. So being in hospital for any reason as a patient is a time in your life when you're at great risk of a deep vein thrombosis. In fact, another horrifying statistic is that more people go into hospital and subsequently die of a deep vein thrombosis, a clot in the leg which then moves and goes to the lungs. More people die from that than MRSA, or the killer bug Clostridium difficile, or breast cancer, or road traffic accidents, all put together. So that is the main risk factor for DVT if you want any worrying time. And that's why you see so many people wandering around hospital with those white socks on. Because now, again, NICE has said, a few years ago now, that everyone going into hospital should have a DVT risk assessment and appropriate measures to minimise that risk. Varicose veins are not really a strong risk factor, but if you've got other problems going on and you've got bad varicose veins, your risk is slightly increased. And we know that if you have your varicose veins treated, your risk goes back to what it would have been had you not had vein problems. That's not a strong enough reason to have your veins done, because the additional risk is quite small, but it is a risk factor, and there is now good evidence.
I'm a little concerned about superglue being used in vein surgery. What happens to it when it gets in the body? Is there any way it can get dispersed?
The superglue that is used is very quick setting, and it bonds permanently. This superglue, as I say, has been in use in medicine for 50 years, and it doesn't break up and turn into anything nasty, and it doesn't cause cancer. It doesn't appear to break up and move around the body. The formulation that's been used for veins has been in development for over 5 years. It's had extensive laboratory testing. It's had a lot of animal experiments, so it's been put in the veins of animals and looked at. It's been looked at under the microscope. You can take the veins out and you can look at them under the microscope at various times after treatment. And it appears that there are no safety concerns. The company, Saffion, is very meticulous about who does their superglue treatment. I had to go to Hamburg in Germany for 2 days training before starting to use the VenaSeal system. And then I had to sit an exam. And then I had to have my first case observed by a person from the company to confirm that I was doing it properly. Only after those 3 safeguards were we allowed to provide this treatment at our clinic. And we have actually had Rod Rabe, the inventor of the technique, come to our clinic to see us performing the treatment. And he did give us a rather ringing endorsement, didn't he, Mrs. English? Yeah. He said, and he's allowed me to quote him, is that he's been to all the clinics that provide this treatment, and we do the procedure as well as anywhere in the world. So that's pretty good. And he's allowed me to quote that, so I'm not saying anything that's been made up. So yes, you're right to be concerned. With any new treatment, you need to be assured that it's safe and that it's effective. one of the things that we're very pleased about in our clinic is we are never the first. I would never want to be the first having any treatment, and I wouldn't want any of my patients to be the first. So we don't do anything that's experimental. We've never been the first to do venous closure, never been the first to do laser, never been the first to do ultrasound-guided foam sclerotherapy, and we weren't the first to do VenaSeal. We're usually among the early adopters, but we like to see the published results first before we adopt anything. We look very carefully before we take anything on. All the things we do are safe, that we would have done ourselves, that we're happy to do for others. One of the tests I use is, if I wouldn't do this procedure to a member of my family, I wouldn't do it for a patient. And I think that's a good way of deciding what's safe and what's good. I went to Lyon and I looked at steam and I thought, I'm not convinced. I don't think I would offer this to a member of my family in preference to another treatment. So that's why we don't offer it yet. Evidence may come through, it's not there yet, evidence may come forward that there are reasons to choose steam in certain situations, in which case we'll reconsider it. We keep an open mind, but we don't do anything that's experimental. So I hope that answers your concerns about Superglue and VenaSeal.
VenaSeal, is that preferable over the other treatments? I mean, why would you select that one? I can see there's benefits because you're just getting out of the clinic quite quickly. And is that the one reason really selecting that?
Yes. One of the questions I get asked a lot is, why choose VenaSeal over some of the more established treatments like laser and venous closure? It is relatively new, so although the results 12 months to 24 months after treatment show that it's as good as endovenous laser, it's not better in terms of the risk of recurrence. However, there are some features that some people may prefer. They might prefer the idea of not having local anaesthetic jabs. For example, some people are very, very nervous about local anaesthetic jabs. Very nervous, almost needle phobic. For them, having Superglue would be an advantage. It's one local anaesthetic jab. There are some people who think the idea of wearing a compression stocking even for a week is dreadful, in which case VenaSeal gets over that problem. Is it better? Well, it's more expensive. All new treatments tend to be more expensive. The price may come down. There may be other formulations from different companies which will put the price down. At the moment, the main barrier to acceptance is the quite high cost of VenaSeal in comparison with radiofrequency and laser. But we don't have a lot of patients who prefer it, but we have probably up to 20 people now who've chosen VenaSeal for those reasons mainly. They want one local anaesthetic jab, they don't want to wear a stocking, they want to drive themselves home straight away, and they want to have absolutely no restrictions. So they can get on a plane, they can drive, they can do whatever they like with just one little band-aid on their leg. Is it better? Well, it's a value judgment really. It seems to be just as effective. One of the ladies that we treated last year, she had 4 major veins in her legs which were refluxing, so 2 in each leg. And in fact, that was the person who Rod Rabe came to observe us treating. Now, she would have had to have had quite a lot of local anaesthetic jabs. She had 4 local anaesthetic jabs, and she walked out with 4 band-aids on her leg. So she was delighted. I think it's really a question of individual taste and discussing the pros and cons, discussing the cost, and seeing what works best for you. But as I say, everything that we do is effective, and we wouldn't offer you anything that wasn't very, very good.
Thank you.
Well,
Is the cost the same if you've got one varicose vein or you've got lots of varicose veins?
Yes, that's a very common question that I get asked. A lot of people ask me, the cost in your brochure is described as per leg or per procedure. Does it matter if I've got lots of veins, one vein, 5 veins? Well, one of the things that we are concerned about, particularly for people who are paying for themselves, is that we don't want them to feel they're getting into something that they can't afford. So we like to keep things very transparent. That is the price. If you've got a lot of veins on your leg that need treatment, it's the same. We don't charge you per vein or per hour. So you know, before you commit yourself, what the cost is going to be. And we like to give people a per leg idea. Some people require combination treatments, so some people require endovenous laser treatment and foam sclerotherapy and phlebectomy. We don't add all of those up, we just charge the headline fee for the laser, and we do the other treatments as part of that. So there's no totting up. It's not like a bill at a restaurant where you have all the various items added up, and that. We tend to try and make it very transparent so people don't get any surprises. I wouldn't want to start private treatment not knowing what the figure is going to be. Private treatment can be very expensive, particularly if you go into a private hospital, and the charges can add up very quickly. We try to take the risk of that away. So if, for example, you have a concern after your treatment, you can speak to us. We don't start the meter running. We'll give you advice over the phone. If you're concerned or you need to come and see someone and have an additional scan, there's no charge for that. If when you come back we haven't achieved those excellent results because there's still a lumpy vein present and we think we can improve that for you, we will treat you again at no extra charge. And if in the unlikely event that something's not right, we will see you and do our very best to put it right for you at no extra charge. So we hope that everything's transparent. Now, for people who are insured, it is slightly different. The insurance companies like to be billed for everything that we do, and we bill for everything that we do. So we have to have a system where if you come and see us, we bill you. If you have a concern and you need to see us and you have private health insurance, you need to tell your insurance company, and when you come, we bill you, because that's the way the private insurance companies work. But for people who are paying out of their own pocket, we keep it as transparent and as simple as possible, because we don't want you to be surprised with unexpected bills.